Hello, class. Welcome. Today we are focusing on Curry 5th edition, chapter 1, before, during, and after the ultrasound examination. If you go ahead and flip to page 2, it begins by talking about how an ultrasound student would become a sonographer. So they talk about how it's beneficial for you to have a science background or have previous history in healthcare. However, there are many institutes that can help students. And then it does talk about what the curriculum, so what you're learning in school should include: anatomy and physiology, physics, patient care, pathology, and medical ethics. Halfway through that paragraph, it says the American Registry of Diagnostic Medical Sonography, which is the ARDMS, the ARRT, and the CCI. I know it mentions 3 different areas there, but we're going to focus on the ARDMS because that's the one that's the most widely accepted. And this is a professional organization which offers credentialing for sonographers by written examination. So the exams are written at this time. If you continue reading, it says certification can be earned in multiple specialties, including the abdomen, OB-GYN, neuro, breast, sonography, adult and pediatric echo, as well as vascular. So those are just a few of the specialty exams that are offered. Out of those, I would say that OB or abdomen are probably the most common, and then followed by RVT, which is vascular. It says the sonographer may also be required to take an SPI exam at the time of certification. At present, there is no assessment for scanning ability. So at the present time, they don't assess whether or not you can scan, if you're good at scanning, if you can recognize normal and abnormal anatomy. But you do have to pass 2 written exams prior to becoming certified through the ARDMS. So the first one, which you guys know very well, is the sonography principles and instrumentation, which is an SPI or a physics exam. And this one can be completed while you are in the program. It is a graduation requirement for us. So you guys would all have this before you graduate from the college. The second exam is a specialty exam. And like the book mentioned, there's different areas of specialty. The combination of these 2 is what registers you through the ARDMS. And you only have a 5-year window between the 2. So that means 5 years after you take your SPI exam, you do have to pass a specialty exam. And that can change. Obviously, that is a policy of the ARDMS, for example. However, it's important to, I always think like 5 years seems like a long time, but many of you guys are busy and you guys have a lot of plans and it can go by in a flash. And so you want to definitely make sure that you're not waiting for that specialty and you are taking it as soon as you possibly can. Also, the longer you are out of school, the harder it is to get back into studying and, getting in that routine of like that student mindset. Further down the page, on page 2, it talks about it says sonographer's primary work involves using ultrasound imaging equipment to produce cross-section images of anatomy and diagnostic data. The responsibilities of an ultrasound tech: you must have excellent communication skills, strong computer skills, ability to obtain and record patient data that is pertinent to the ultrasound study, proper use of the ultrasound system, which is the machine, provide quality patient care, acquire, analyze, modify, and select images to store and to present for the physician, use ultrasound terminology to document the technical summary. So technical summary is like the worksheet that you would fill out at the end of your ultrasound that talks about what you saw on that patient. And then assist with ultrasound guided invasive procedures. So invasive procedures would be like a biopsy, an aspiration, paracentesis, thoracentesis, and then knowledge of standard precautions, which we're going to talk more about what standard precautions is on page 3. Understanding standard precautions. So On page 2, it kind of introduces us to standard precautions. It says increased concern for healthcare workers becoming infected with bloodborne diseases through accidental needle sticks and spills was the reason that OSHA decided to issue a standard design to protect these workers. So go ahead and highlight that OSHA issued a standard design to protect workers. So they're going to protect workers against major bloodborne diseases that healthcare providers may be exposed to on the job. So bloodborne diseases, and these are Hep B, HBV, hepatitis B, syphilis, malaria, and HIV. And so I don't believe they go into what these are in the text, but it's important to know, a little bit of information of these. And so these are bloodborne diseases that anybody who works with patients. So if your patient has these and you handle your patient, you may also contract these bloodborne infections, right? And so we can get these through accidental needle sticks and also accidental spills. Now, you may be thinking, well, why would I be around a needle? As an ultrasound tech, we do work with a team of people. You might be asked to come to surgery. You might be doing an invasive procedure, such as like a breast biopsy, a thyroid fine needle aspiration, a liver aspiration, like, we do liver, kidneys, anything that we can get to with a needle. Now, if it's too hard to get to that location to do a biopsy or an aspiration, then they'll send the patient off to surgery. But, if we can reach it with a needle, they'll use ultrasound. It's less invasive, it's cheaper, it's easier than sending the patient to surgery. So you do come across needles and scalpels and sharp, glass containers. And so it says of these, HPV and HRV are the two most significant. They can be transmitted in bodily fluids such as blood, saliva, semen, vaginal secretions, amniotic fluid, cerebrospinal, synovial, and pericardial fluid. So out of those, the ones that sometimes we don't know what they are synovial, which is like fluid that's pertaining to a joint. So like, the back of your knee is like a really common area that people get like a fluid collection right behind the knee where that popliteal vein and artery are. And so, and then pericardial is around the heart. And so again, these are fluids that we do come in contact with regularly. Now, I can't say that I've come in contact with all of these regularly, but I think working at a hospital at some point, I have come in contact with all of these. It just really depends on where you work. It says you must use caution when handling blood or organs or tissue from known HIV, HBV patients. You can protect yourself with getting a vaccine. It's 3 vaccines over 6 months, and it's offered in most healthcare facilities. So most of the time where you work, they will offer you protection against, if you, it's not like you're going to be exposed any less. So no, that's not it. You're still going to be exposed. You can still get it, but the only thing is like your body will be able to fight it more effectively and more efficiently. Highlight that vaccination does not reduce exposure to the disease. It does protect the healthcare worker if the exposure does occur. Accidental injuries from contaminated sharp objects such as needles, scalpels, broken glass, and exposed dental wires are among the most common ways these diseases can be transmitted. So I don't think I've like really come in contact with like dental wires, but I don't think I'm ever in anybody's mouth that closely, but that's what it says here. It says exposure can also occur from open cuts, skin abrasions, dermatitis, and acne, mucous membranes such as your nose, mouth, and eyes. So touching a contaminated surface in transferring that infectious material to your mouth, to your nose, or to your eyes is like an indirect means of transmission. So there's like direct, right, and indirect. And so it says it is known that HPV can survive dried on a surface at room temperature for a week. So this just kind of goes, just kind of highlights the importance of like cleanliness, how important it is to clean your ultrasound machines, to clean your transducers, to clean the cords, clean the bed, clean the handrails, right? Clean everything that's coming in contact with your patients. Um, some patients are open and upfront and very like honest about what they have, and some don't. Some keep it secret and they might be a little bit of embarrassed or sometimes ashamed, and and so they don't really tell you. So we do come in contact with patients that can have some of these bloodborne diseases and we really don't even know about it. So that is very common. Okay, standard precautions on page 3 requires treating all patients as if they were known to be infected with HIV or HBV or other bloodborne diseases. So this is treating all patients as if they know that they have these diseases. And so that sometimes students kind of take that the wrong way. Now, it doesn't mean you have to act, disrespectful, unprofessional, like, oh, I'm grossed out. I don't want to, I'm scared. You definitely don't want to act like that. I mean, you can imagine that that would make you feel pretty bad if someone was treating you that way. Um, it's just saying like, hey, be aware, be cautious, like, don't be a bozo, like, clean up after your patient, like protect yourself, protect the patient, just be like more mindful about what you are doing. So it says strategies to reduce risk of exposure. So things that we could do, employee work practices that reduce your personal risk of exposure, such as proper cleaning and disinfection of your ultrasound console and probes, wearing personal protective equipment, PPE, and hand washing are essential. Hand washing with soap and water or alcohol-based hand rubs should be performed for at least 30 seconds before and after. Offering vaccination against HBV and annual influenza vaccinations can also reduce the risk. Proper cleaning and disinfection of your ultrasound probes and consoles. So if you didn't get it the first time, they're going to tell you again. Disposing of sharps and laundry in the appropriate containers. So when you do work at a at a facility, a healthcare facility, there's different things that we try to do to like just maintain safety. And so like, there's different like machines like autoclaves that like will disinfect material for us. For example, like there are these like this picture here, self-sheathing needles. So like once the doctor uses that needle on the patient, they'll pop that green cap on. And once that green cap covers the needle, you can't take it off again. So it's like, then that like infected or possibly infected needle doesn't come in contact with you, after that point, once it's like that cap is clicked into place. This guy, he's covered, gloves, eye gear, head covered. He has that like plastic gown on that's covering his clothes to protect himself against, whatever it is that he's handling. So we talked about personal protective equipment, and sometimes, we're as ultrasound techs, we're really used to the masks and we're really used to the gloves, but there are some patients that will require a little bit of a higher level of personal protective equipment. So, there are like these like little booty coverings, like shoe coverings. There's like sometimes you're required to cover your hair before you walk into a room. Sometimes you're required to like put that plastic gown that covers your scrubs when you walk into the patient's room. So there's like various levels of PPE that we're required to use while we're working. Um, Everything, should be like nicely marked, right? This is a sharps container. Anything that's sharp would go here. So you would put like needles and scalpels and so on. There's certain bins that are used just for medication. There are certain bins that are used just for soiled linen. And so it's important to put things where they go. And that is because they are like discarded differently. So for example, old medication or like medication that's only been like half used, right? And it gets thrown out. They don't just throw it out in the dumpster. because there are people that will, that are addicted to different medications. And so they will specifically target trash cans at hospitals hoping to find this medication. So it's actually like they get dispose of it by like burning it. And so that like no one can ever really get their hands on it. So it is important to follow, you know, um, the layout of your facility and put things where it needs to be for the safety of you and for the safety of others. Okay, we're going to jump over to where it says before the ultrasound examination. A sonographer is responsible for acquiring patient information before the examination. So definitely, what is your first name? What is your last name? What is your date of birth? Do you know why you're here today? Do you know why your doctor sent you? If your patient says, no, I don't know why I'm here, you don't just want to be like, okay, cool. You want to be like, oh, well, why did you see your doctor in the first place? Do you remember your doctor telling you anything? Was your doctor concerned about anything? Do you have a family history of anything? Have you had any recent surgeries? I can't tell you how many times I've met new techs and they're like looking and looking and looking for the patient's gallbladder. And then I'm like, hey, like, do you even have a gallbladder? And they're like, oh no, I had my gallbladder removed 15 years ago. And it's like, okay, we just wasted 15 minutes looking for something that's like never going to be found because it's been removed. So it's important to speak to your patients before you start scanning. It says the process begins with the sonographer reviews the ultrasound request form and the patient chart. An ultrasound request form should include the patient identification data, clinical symptoms, type of the exam requested, and the reason for the exam. And so this is an example of two different request forms. So these are requests of, that the doctor would write up um, for you to know why you are doing this ultrasound. So sometimes they're very easy to read, like really nice, really organized. You can tell where they're coming from. The doctor will, write down a lot of good information. But most of the time, we get something that looks like this, where you're like trying to piece together like letters and words so that you can kind of figure out what type of ultrasound you're supposed to be doing. Um, so here you can see that they put like P ultrasound to check position of IUD. So we're guessing that P is a pelvic ultrasound. And so they say no IUD strings are seen. The IUD hook was used and there was no IUD. So like you're kind of like piecing things together. If you're ever not sure of what you're supposed to do, I would definitely call and verify. So all of them should have like the doctor's information on them. For example, like on this one, you could see like the doctors up here and you can like call this location and ask to speak to those doctors. And definitely don't go doing an ultrasound if you're unsure what type of ultrasound you're supposed to be doing, because that could definitely get you into trouble. So these are an example of a patient's chart. Now, only patients that are admitted to a hospital would have a patient chart. Like none of us are walking around with these charts in our purses, right? And so for you to check a patient's chart, it would be a patient that is admitted to the hospital that you work at. And so like when You know, for example, if they want me to do a thyroid ultrasound on a patient and he's in room 302, I'm going to go up to the third floor. I'm going to go find where the charts are. Usually they're labeled with like numbers, so I'll pull the chart that says 302, make sure it's the right patient, and I can check the orders, and then the order will be there. And so if they're outpatients, right, like they're coming to you just for the ultrasound and then they're going to go back out of the hospital. So if they're an outpatient, they'll have a doctor order something like this, a request form. And then if it's an inpatient, you'll get that chart. All right, so we're going to jump to page 5 so you guys can read more about what I was saying about how charts usually stay in the referring physician's office and the sonographer won't have access to those. On page 5, it talks about clinical criteria. So, what should you be responsible for as a medical professional? So, wearing appropriate attire, wear personal identification badge. You want to introduce yourself. The next bullet, you want to be courteous and respectful interactions. Conversations have to be proper and professional. Never discuss the sonographic findings or offer even your opinion for the study with the patient. Only physicians can legally render a diagnosis. And so, as an ultrasound tech, man, the pressure is real. You're in that room with them for like with the patients for like 30 minutes at a time. They don't have anything to look at but your face. So they will tell you, like, oh, I can see in your face that you're scared, that you're concerned. Did you see something? Oh, your eyes got big for a second. And you're just like, so you kind of do over time like develop a poker face. You're kind of like a little bit more callous to the screen, and you don't let your eyes get big when you see something or look sad when you see something sad. Um, you just want to make sure you continue looking forward, and you make sure that you don't give your opinion or your idea of a diagnosis, because we're legally not allowed to do that. In the next bullet, make very sure that you have the correct patient. So obviously, there's some very common names out there, first and last names. So if it is a common name, you want to take extra precaution to make sure that you do have the right patient. Um, Briefly explain the examination to the patient, inquire about the patient's symptoms, history, surgeries, instruct the patient in slow, clear, and appropriate manner. When required, help the patient to address or undress, assist the patients with medical equipment. Before helping the patient onto an exam bed or a stretcher, check that the brakes are set to ensure that the table and stretcher do not move. Have a handheld stool available to assist shorter patients onto the table. So yeah, sometimes our patients do need help dressing and undressing. I understand that that might be like a little bit uncomfortable for you, a little bit awkward, but imagine like a patient that's like 94 years old and she's barely moving, and you're just like, okay, you're gonna take your pants and underwear off and you're gonna put this gown on open to the back, and then I'm gonna need you to hop on this bed and lie down and cover your legs with a sheet. She's probably not gonna get that far if she can even, handle that much direction at one time. And so you're just, being really unhelpful to her. And so you kind of have to meet the patient where they need to be met. And that's like what's going to set you apart from like, the not so good medical team members and the great medical team members. Be familiar with your institution's isolation policies, be familiar with sterile equipment, be familiar with procedures. Most transabdominal pelvic studies, so we're talking about a pelvic exam that's done transabdominally, requires the patient to have a full bladder because it can cause the patient discomfort. Scan prudently, so just scan quickly and get to the point and complete your exam in a timely manner. Some institutions require patients to sign a consent form prior to an endocavitary study. It is recommended that the exam should be witnessed by another sonographer or a healthcare professional. This is an essential requirement for transvaginal exams performed by male sonographers with female patients. The sonographers and a witness's initials should be part of the permanent record. So what that's telling you is it's telling you that sometimes when they do endocavitary, so like endorectal, endovaginal, they'll have you sign a consent, they'll have the patient sign a consent form. Now, I've done both of those, and everywhere I work, we didn't have the patient sign a consent form. It was like really like word of mouth, like, hey, this is what the exam is going to be like. Do you accept to do it or not? And, it was like easy, yes or no. If they looked very hesitant, when I asked them that, and like I kind of felt uneasy, like they were really, then obviously I would always explain the benefits of it, because it is beneficial for them to get it. We're closer to the anatomy, less possibility for your probe to attenuate, and so the images are so much better when we go endocavitary. But if they don't want it, they don't want it, and that's the end. You would just write down on your worksheet that the patient refused it, and like possibly the reason if you know the reason. If you are a male sonographer, you do require a female, so it can't be two males, but a female chaperone in the room with that patient. And it's just like a way to protect you. And so sometimes this is a little hard because sometimes there isn't like an extra lady around that you could be like, hey, can you watch me do this ultrasound? So sometimes, it's a little bit hard for like a male tech to, approach that if they don't have the possibility of a chaperone. Know how to handle all ultrasound equipment, practice attaching and detaching transducers from the machine, be comfortable operating the image documentation system. So what I have here is a couple examples of technical observations, which are worksheets. And so at the beginning, we have a renal worksheet. The next one is breast. And then the last one with the blue is testicular. And so you could see that they all, there's some similarities and there's some differences between them. And these are the worksheets that you would fill out at the end of your ultrasound. And it tells the doctor what you saw, what you thought. And so the doctor will use your images and use your technical observation to determine on their own what they believe to be the issue or the problem with the patient, if any. And usually there is a picture of anatomy on each worksheet. And so, like for example, if you see like a right renal cyst and, you would draw the cyst in where it is, and, you would, talk about, what it is, like the size of it, like 2 by 4 by 6 centimeters or what have you. They like to use the pictures so that like, we can draw the masses or the abnormalities as well as write about them. Okay, so a good part of the chapter here, moving on, it has so all of these like green pages are terms and their definitions, which I don't really look at them now, but I think when I was new, filling out those technical observations, you have to use medical terminology. And so, sometimes you're kind of struggling to find the words to express what you saw on the screen. So these are nice. This is a nice section of your book because you do use these words regularly, daily, to discuss with physicians what you see, whether it's like you're discussing with them verbally or you're writing it on your technical observation on your worksheet. So we have acoustic enhancement. And so you guys should know what this looks like. And so you guys know that the enhancement is like that brightening spot. It's always posterior to a structure, so it's always back and behind it. And it's usually underneath a fluid filled structure. And so this is an artifact, which means like it's not an accurate representation of the body. However, it is a helpful artifact, right? It does help you determine if that structure may or may not be fluid filled. Enhancement is commonly seen posterior to fluid filled structures. Another one that you guys want to know is shadowing. Shadowing is the opposite of enhancement. It's actually where your image becomes dark or shadowed posterior to a structure. And so this is edge shadow, which is like only on the edge of that like fetal scalp, fetal head. And then this is shadowing posterior to the gallbladder stones, these little itty bitty stones inside of the gallbladder. But again, it's a helpful artifact. Shadowing is usually seen underneath solid structures and not fluid structures. Alera, you guys definitely want to know about Alera, as low as reasonably achievable. So basically it's just telling you that when you do an ultrasound, you really want to try to minimize the patient risk. You scan really just what you need to obtain that information for the radiologist, and then we're done. You want to know the words anechoic, what that means, echo free, anterior. Is another one, right? So you guys know that anything at the top of your screen, the closer it is to the top, this is the anterior or like the front of the patient's body, and then the bottom would be posterior, which is the back side of the patient. Artifact, what is it? So it's a mistake, right? It's not supposed to be there on the screen, but we do get a lot of artifacts in ultrasound. Another one is ascites. Ascites is an accumulation of fluid. It's free floating, so it's like inside of the patient's abdomen, and we can use ultrasound to drain it. Attenuation. So attenuation happens. So attenuation and beam divergence in your list, they kind of go hand in hand. So as the beam spreads out, the ultrasound beam that's coming out of your transducer, of course, as the beam spreads out, it does lose its amplitude, power, and intensity, which means that it attenuates. Stones. So here we have a couple different pictures. We have gallbladder stones there at the bottom with the yellow arrow. That's a stone that's inside of the urinary bladder. So it probably came down from the kidney down the ureter and just like is hanging out inside of the bladder. And then that first picture, that's a nice good size stone in that kidney. And so that's a calculi or a stone. Calipers, you guys know what calipers are. Calipers are used to measure. So for example, like they measured the size of this stone, and calipers measures the distance between. Color flow Doppler, you guys should know what that is. Complex mass. So here's an example of a complex mass. A complex mass is a mass that contains both tissue and fluid. You guys want to know what the word contralateral is when you describe the position of something. On page 8, coupling agent, which is just like a fancy way of saying gel. We have cystic, which a cystic structure is made out of fluid. Depth of penetration, it's how far the beam can travel in the patient's body. A diffuse disease, so diffuse disease is an infiltrative disease, which means the disease will take up the entire organ or the majority of the organ. So like, as you can see here, we have a picture of the liver, and you can see how throughout the patient's liver, there are these hypoechoic masses, right? So it's not just like one part of the liver or like one mass, but rather it's infiltrative, it's diffused, it's everywhere. You guys should obviously know what distal is anything that would be described as being farthest from the point of origin. So for ultrasound, the point of origin is your heart. And so like your fingers are the most distal part of your upper extremity because they're the furthest away from your heart. And so like distal is the furthest, proximal is the closest. So like, for example, like your shoulder area would be like the proximal portion because it's the closest to the heart. You guys also want to know what echogenic is, which I'm sure everybody knows. Extra organ pathology. So this is like a disease or pathology that originates outside of the organ and could be like extending into the organ or pushing up against it. Focal and multifocal changes, focal zone, grayscale. These are all words that you should get comfortable with. So here's an example of like focal or multifocal change. And so this is like one area, this like arrows pointing to like one area of the liver that appears to be a little bit more hypoechoic than the rest. And then here you could see this one really well. So it's like, it's kind of like a patch. And so it's not like affecting the entire organ. It's just in like one area. So we call it that focal or local. And that is the opposite of diffused disease. Heterogeneous, any organ, so when I'm describing something as being hetero, I kind of scan my eyes through it. And if, parts of it look really different, like you can see how here it's very echogenic, here it looks more cystic, here it looks more hypoechoic. So those don't really match. They're not isoechoic. They are very different. So that's when you would describe it as being heterogeneous, which is the opposite of something that is homogeneous. So here we have testicles, and the testicle does look more homogeneous. So like all of the grays that I'm seeing, they do kind of match throughout the organ. Hyperechoic, hypoechoic, inferior, infiltrative disease. Infiltrative disease is basically the same as diffused disease. Interface, intra-organ pathology. Ipsilateral is the opposite of contralateral. So contralateral, and we did it a moment ago, it's the opposite side. Ipsilateral is the same side. You guys also want to know isogenic, isoechoic. You guys want to know what that means. Lateral, long axis, longitudinal. So I'm just like picking out a few of the words. You definitely should read them all, but many of these you guys know. Medial, medium, these are all very common. On page 10, necrotic. So this is like tissue death. Parenchyma, which is like just like tissue. You're just like describing tissue when you say parenchyma. Pleural effusion. So here we have an image of pleural effusion, and pleural effusion is fluid that is around the lung. So it's not inside of the lung, but around the lung. And we can use ultrasound to drain it. So another location is posterior that you guys should know, proximal. Septations. So septations are also called loculations. And so they're just like these little flaps of tissue, flaps of epithelial tissue that kind of form, and they compartmentalize structure. So like kind of forms little compartments. And then solid mass, superficial, superior, TGCs, through transmission, transducer. I mean, my gosh, if you guys don't know what transducer is, can you imagine? Transverse scanning, and a true cyst. For a true cyst, it does go a little bit more into detail with the classification. You guys want to make sure that you guys read that and understand that as well. And now I'm going to point out just a couple areas of the chapter that you guys should also be familiar with. So on page 12, there's surface landmarks at the top. So things that you want to highlight in that first body, you want to make sure you guys know what the xiphoid process is. You guys can feel it. Usually when you feel these structures on your body, it does help you identify them, and you can feel them on your body. That's why they're called surface landmarks. So the xiphoid process, the umbilicus, the sternum, in the middle one, sternum, iliac crest, symphysis pubis. And then you guys should know the regional divisions of the abdomen as well as the quadrants. And we do use the quadrants a lot. So that's important. When you guys are on page 12, for patient positioning, so it says the best patient position is determined by what will produce the optimal views of the area of interest. So like a supine position is often used where the patient is on their back. With the choosing the transducer, that's important to know. It's important to know like when and why you would choose a high or a low frequency, which like we just did physics, right? We all just like came out of physics. So hopefully we're good there. Using a transducer, holding the transducer like you would a pencil puts the least amount of strain on the wrist and affords ease of movement. I say this all the time. Make sure that you guys are resting your pinky and like that part of your hand on the patient. It will really save your scanning arm and like allow you to have longevity in the field. So on page 13, he just kind of touches on like common things that we discuss. So parenchyma, which is just like tissue. Usually most tissues are described as being homogeneous. Now, there is like a few exceptions, just so you know, like the kidney is normally described as being heterogeneous, but usually like with ultrasound, homogeneous tissue is normal. Here we have a picture of muscles. So if you look at how muscles are described, they're described as being homogeneous, but the second bullet says that they are hypoechoic. And the third bullet says muscle bundles are separated by bright bands of fibroadipose septate. So muscles have like a very distinct look. So depending if you're in long or trans, but for the most part, they are hypoechoic, so they are darker. And then they do have these like linear striations, so like these white bands that travel through the muscle. And here's like another picture. And so muscles are the only part of the body that look like this. This is a thyroid. But I like this picture because like it's pointing to the hypoechoic muscles that are around the thyroid gland. And so those like fibroadipose septate, those lines are what kind of keep the muscle in their shape. You know, muscles have like a distinct shape. It's not like just like a blob of tissue. And so it's those fibrous bands that keep the shape. I kind of think of them as like being rubber bands that kind of holds the bulk of the muscle together. Placenta could be described very differently. So depending on the age of the placenta, placentas start off as being like very uniform, very homogeneous, and then over time, as like mom's body and baby's body uses this placenta, it does become very like heterogeneous. And so it does change. And so you'll read that when you look at the description for placenta, you'll see how it does, the echo texture does change. Okay, you guys want to go ahead and read what tissue is supposed to look like. So when they're saying tissue, they're talking about like the skin layers at the very surface of your image. So like these guys here would be described as like the tissue. So they're very bright or hyperechoic. They're also linear, right? Like your skin is going to look like a bunch of lines. You might want to write the word linear in there if it's not. On page 14, any fluid-filled structures. So they're giving you examples of what is a fluid-filled structure. So like a blood vessel is filled with blood, ducts, you know, they're filled with bile. The umbilical cord is filled with blood. Amniotic sac is filled with amniotic fluid. Brain ventricles are filled with cerebrospinal fluid. Anything that's filled with blood, with urine, with bile, right? And so what do they look like on ultrasound? If you look over where it says the normal sonographic appearance, they're going to be anechoic. The walls are usually echogenic or hyperechoic, and it may exhibit posterior transmission, which like in ink, another way of saying that posterior transmission is posterior enhancement. And so fluid filled structures often do that. For the GI tract is also something that it changes depending on what is inside the GI tract. So for example, if you look at the first bullet, it says that the walls should be hypoechoic and they're surrounded by fat. The next bullet, the appearance of the GI tract lumen varies depending on its contents. So if it's filled with fluid, it will be anechoic. It's filled with gas or air, it will be highly echogenic. The next bullet says it could look complex or mixed with anechoic portions from fluid, portions that vary in brightness from partially digested food. And then the next bullet, it can even cast shadows where there is air or gas that's present inside of the lumen. And a collapsed bowel, so has a very distinct appearance that looks like a target sign or a bullseye. So this is bowel that's like empty. It's just like completely collapsed and closed. This is bowel here that's fluid filled. So you could see how there's like anechoic and there's some like enhancement here. This is what, it may look like when there's like this is the stomach, but this is what it'll look like if there's like partially digested food. You kind of see these like little particles floating around in the fluid. So it really just depends on what the patient ate, how long ago, and where that food is within the digestive tract. On page 15, you guys want to know some of the information here. So the first bullet said scanning should be fluid and not rigid. Obviously, you don't want to look like you're doing the robot while you're scanning a patient. You want to look cool, calm, and collected. A couple bullets down, it says the amount of pressure exerted on the skin surface by the transducer can be varied to improve image results. But you guys have been scanning for a while and you guys all know that breathing techniques, these are really important. So breathing techniques, inspiration. So when the patient takes a deep breath in, it says that everything below it in the abdomen moves down. Deep exhalation, everything moves up. If you find that the patient's normal respiration causes too much movement to adequately visualize, have the patient momentarily stop breathing. And so that's one that I don't use so often is the like just stop breathing one. I find that one's like pretty hard for patients to do. Like imagine just like stop breathing right now. Like you could do it, but like how long can you hold it? So usually if I have a patient just stop breathing, I am more mindful to have them release the breath sooner. Also, if you've ever had ultrasound yourself, it's annoying when they forget about you and you're just sitting there like 2 seconds away from passing out, right? Your life's flashing before your eyes and you're sweating. You're like, oh my God, am I ever going to take a breath again? And so it's just like something that I'm very mindful of because I don't really like holding my breath. And so I've always been careful of that with my patients. On page 16, I want you guys to remember the anterior approach for sagittal scanning. So when the patient is lying supine, so it's that first picture on page 16, the patient is lying supine and the transducer is in long, right? That's what sagittal means. And you guys want to know that the top of the image would be the anterior part of the patient, the bottom part of the image would be the posterior, and then you have the superior and inferior. So that's like a nice way to orient your image. And for transverse on the next page, on page 17, you also want to remember the first image. So again, the patient's supine, but now you could see that instead of superior and inferior, they switch those out for the patient's right and the patient's left. On page 19, you have a few little bodies up there at the top. So you want to know what supine looks like, prone, right lateral decubitus, which we call RLD, LLD, RPO, which is right posterior oblique, LPO, semi-erect, and erect. And so those are just different positions that we would scan the patient. Some patients can be moved, some patients cannot be moved. And that is probably something that you need to make the judgment call on. And if you don't know, maybe you need to ask the patients. nurse because, if they look like they're in bad shape, you probably shouldn't be moving them around too much. And then at the bottom, you have that upper torso image with the sternum and the ribs. And so you guys want to know what subcostal is. It's where you have the transducer angled superiorly just underneath the ribs, and then intercostal where the transducer is moved up and in between the ribs. And so you use these approaches in, trying to obtain appropriate images. So we talked about, what your image looks like in long and trans. On page 23, you have a really nice picture and they've labeled it for you. So on page 23, you can see that the top of the image is anterior, posterior, superior, and inferior. I've always kind of learned it like this. So this only works if you're in long, right? So if you're in long, imagine that the patient's head is up here and their feet are down here. So anything up here, right, would be superior, like towards the patient's head. Anything on this side of the screen would be inferior towards the patient's feet. And then obviously anterior and posterior, right? That like never really changes. And so you have a similar one for transverse on page 25. So on page 25, the first image there is in transverse. And you can see that the superior and inferior have been switched out for right and left. And so, sometimes we don't think this stuff matters. And I probably thought the same, like, why does it even matter? And I realized that it matters when I went into surgery or when I started working with doctors that were trying to stick a small needle into a small mass. And so they're very, like, which way am I going? Should I be going superior? Should I be going left? Should I be? And you're just like, oh my gosh, And so it definitely feels like, those were the times where I was like, okay, I should have paid more attention because I kind of struggled. I was nervous about having the doctor put the needle into the wrong space because I didn't know how to orient my image. So these are the most important parts of chapter 1 that you guys want to study. Of course, go ahead and read the entire chapter as always so you guys can get like full and complete learning. Let me know if you have any questions, and I hope you have a good day.